Good afternoon, and thank you for asking me to present at this HIV-NAT Symposium. I was asked to talk about hepatitis C amongst people who inject drugs and people who are incarcerated. We'll take that one step further this afternoon and think about how we might eliminate hepatitis C in these populations. My name is Marianne Martinello, and I'm an infectious diseases physician and senior research fellow at the Kirby Institute in Sydney, Australia. So in recognition of the burden attributed to communicable diseases, the UN Sustainable Development Goals propose to end the epidemics of HIV, tuberculosis, malaria, and combat viral hepatitis. In May 2016, the WHO responded and adopted the first global viral hepatitis strategy with the ambitious aim of eliminating viral hepatitis as a public health threat by 2030. To put that into some context for this talk, in 2015, of the 71 million people who are living with hepatitis C, 6.1 million reported recent injecting drug use, 8% of the hepatitis C infected population. In the same year, there were 1.75 million new infections, of which 23% were attributed to current injecting drug use. If we're going to eliminate hepatitis C, we need to target the populations and the people who are most at risk. So for the next 20-25 minutes, we'll think about whether or not hepatitis C elimination is feasible amongst people who inject drugs, and look at DA treatment outcomes and reinfection incidents in this group. We'll think about what lessons we might be able to take from the Australian response to hepatitis C, and end with some of the key remaining challenges and consider some strategies that we could use to enhance hepatitis C elimination amongst people who inject drugs. Before we begin, I'd just like to remind everyone of the WHO elimination targets. As you can see, there are two key impact targets. The first of which is a reduction in incidence of hepatitis C by 80%, and the second is a reduction in mortality by 65%. The WHO also proposed 5 service delivery targets. These include marked increase in the number of people diagnosed and treated, and of particular relevance to people who inject drugs, involves an increase in the provision of sterile needles and syringes. So as is obvious from this table, increasing access to hepatitis C diagnosis, treatment and prevention services amongst people who inject drugs is critical if the WHO is going to achieve its goals. So do we have the right tools? We certainly have a very effective intervention in the form of direct-acting antiviral therapy. Data from clinical trials has demonstrated favourable responses to direct-acting antiviral therapy amongst people receiving opiate agonist therapy. As you can see, sustained virological response is similar amongst people receiving opiate agonist therapy as compared with those who are not. And this is across a range of direct-acting antiviral regimens, including pan-genotypic therapy. Just to note that many of these studies excluded people who reported ongoing injecting drug use. We also see similarly favourable responses in clinical trials and cohort studies among people with a history of injecting drug use, although relatively few of these included people reporting current injecting drug use. Reviewing these studies in isolation can be a little bit difficult sometimes, as many are limited by small sample sizes, single centre recruitment, and heterogeneous study population definitions. And so as some clinicians, governments still voiced concerns about treating people who inject drugs with direct-acting antiviral therapy, our group at the Kirby performed a systematic review and meta-analysis to look at treatment completion and treatment outcomes for DA therapy amongst people who use drugs. Amongst individuals who were receiving opiate agonist therapy, treatment completion was high at 97% and sustained virological response was 91%. Amongst individuals reporting recent injecting drug use, treatment completion was similarly high at 97%. Sustained virological response was 87%. Much of this reduction in sustained virological response was related to loss to follow-up, and if those individuals are excluded, then sustained virological response increased to greater than 90% in all of the subpopulations. In a meta-regression analysis, looking at factors associated with sustained virological response at a study level, those cohorts that were older and those studies that were clinical trials were associated with SVR. What's most important, though, is that the study population, the makeup of the study population, did not impact on the proportion who achieved SVR. So overall, this data suggests favourable responses with direct-acting antiviral therapy amongst people who inject drugs, including those who report recent injecting drug use. And there should be no consideration to withholding treatment from this group. Another concern that is sometimes cited is reinfection risk following HCV treatment amongst people who inject drugs. And while reinfection risk certainly exists, it should be acknowledged and it should be expected. Again, in this context, our group performed a systematic review evaluating HCV reinfection post-treatment and factors associated with HCV reinfection amongst people reporting recent drug use and recent injecting drug use. Reinfection incidence was 5.9 and 6.2 per 100 person years respectively. Reinfection incidence was lower amongst people receiving opiate agonist therapy at 3.8 per 100 person years. The value of harm reduction. We also looked at differences in reinfection by treatment type, comparing the interferon era with the DAE era. And it was pleasing to note that reinfection incidence was similar amongst people who received interferon-based treatment as compared with DAE-based treatment. So we'll see hepatitis C reinfection following treatment in people who report recent drug use. And we can see that recent injecting drug use was associated with the highest risk of reinfection, while those on opiate agonist therapy had the lowest risk. But this shouldn't be a reason to withhold therapy. Instead, it should focus our minds on the benefits of harm reduction and the need to offer it to people and to consider hepatitis C prevention services while also considering hepatitis C treatment. So we will see hepatitis C reinfection when treating people who inject drugs. We need to acknowledge it and move on. We need to ensure that prevention services are in place, and that includes optimising harm reduction. At a population level, there are benefits from rapidly scaling up therapy, such that we rapidly reduce viremic prevalence in a given setting. We should consider individual level testing and treatment strategies so that people are treated within the context of their injecting network. We also need to ensure that people are adequately followed post-treatment so that if they remain at risk, they have at least annual HCV-RNA testing, that diagnosis of retreatment is made expediently and people are able to access retreatment as necessary. So moving on to what's happened in Australia over the last 5 years. How have we gone in treatment uptake? It's crucial to evaluate our response in order to support a return on investment and guide any ongoing hepatitis C elimination strategies. To give you a snapshot, this is what things looked like at the end of 2015, before universal access to direct-acting antiviral therapy. There are an estimated 188,000 Australians living with hepatitis C, of whom the vast majority reported a history of injecting drug use. Of these, a smaller proportion, 38,000, were estimated to be to report current injecting drug use. And then smaller numbers, again, were on opiate agonist therapy, and some of these people were incarcerated. It should be noted that all of these key populations intersect, and that approximately 25% of people who report current injecting drug use are incarcerated every year. In 2016, the Australian government launched the direct-acting antiviral program through the Pharmaceutical Benefit Scheme. Remember, we're a country that has universal healthcare. So the DAA program ensured that there was unrestricted access for all Australians living with hepatitis C. There was no cap on the total number of treatment courses that could be prescribed, and no cap on the number of treatments an individual person could receive. There was a risk-sharing agreement with the pharmaceutical companies over 5 years. Specialists and non-specialists were involved in prescribing to ensure broad access in the community. And there was minimal administrative duties for clinicians and negligible co-payments for patients to ensure access. It needs to be remembered that this direct-acting antiviral program had a very solid foundation with at least 15 years worth of work by multiple partners to ensure it could be successfully implemented. Australia has had a national hepatitis C strategy since 2000. There was bipartisan support and political leadership for the program. There was a partnership approach with representatives from government, community organisations, clinicians and academia. There has been long-term funding for hepatitis C and drug user community organisations. And in addition to specialist training, general practitioners and addiction medicine clinicians have been involved in education programs since the early 2000s. This will ensure that there is a very solid base for the launch of the direct-acting antiviral program in 2016. As you can see, hepatitis C treatment uptake in Australia following universal access to direct-acting antiviral therapy has been amazing. In 2016 and in the 4 years subsequent, 87,000 people have been treated with DA therapy, with 83,000 of these on the PBS. This equates to approximately 45% of the chronic HCV infected population. A small number of people, 5.8%, have been retreated either for reinfection or virological failure. This response and rapid scale-up would not have been possible without broad societal and political will to get this done. It's also important to note that the effectiveness of the direct-acting antiviral program has been seen across all patient populations and all manner of service delivery. Here we can see high effectiveness amongst people who report current injecting drug use and who are on opiate agonist therapy. We can also see high effectiveness amongst people treated within drug and alcohol services and in prisons. In the community, we've looked at the impact that rapid scale-up has had on a variety of priority populations, including people who inject drugs and people with HIV. Looking at people who report current injecting drug use, we can see that the proportion of people who have reported ever receiving hepatitis C treatment increased rapidly from 10% in 2015 to 55% in 2018. And this was associated with a decline in HCV-NAT prevalence in this group from 51% to 20%. Similarly, amongst people with HIV hepatitis C co-infection, we saw higher rates of direct-acting antiviral treatment uptake amongst HIV-positive people who inject drugs and amongst HIV-positive gay and bisexual men with a variety of drug use and sexual risk behaviours. This high uptake was widespread across the board, and as such, we also saw a population-level benefit with a marked reduction in HCV RNA viremic prevalence, falling from 76% in 2016 to 8% in 2018, nearing elimination of hepatitis C amongst people with HIV in Australia. In addition to the community, we also need to think about the prison setting, and one benefit of the direct-acting antiviral program in Australia is that access is available in prisons. And as you can see, over time, in New South Wales, prisons have increasingly contributed to hepatitis C prescribing, such that they now comprise approximately 25% of all scripts. Acknowledging the large burden of hepatitis C in the prison setting, the STOP-C study commenced to evaluate the impact of direct-acting antiviral scale-up. in 4 prisons in New South Wales. All prison inmates who are 18 years of age and older were eligible for enrolment regardless of their infection status or risk. 3,691 people were enrolled, a mammoth effort. At enrolment, 19% were HCV RNA positive, so consistent with current HCV infection. Of those who were HCV RNA negative, 61% were antibody and RNA negative, so had never been exposed to hepatitis C, and 20% were antibody positive and RNA negative, previously exposed to hepatitis C but did not have current infection. Those who were RNA positive were offered treatment. Those who were RNA negative and at risk of infection, either primary infection or reinfection, were followed. Hepatitis C treatment was rapidly scaled up in the prison setting, with 324 people receiving treatment through STOP-C, with the pangenotypic combination of sofosbuvir-valproatovir for 12 weeks. A small number of people also received treatment through other services. As you can see, the incidence of hepatitis C almost halved following rapid scale-up of DAA therapy, from 8.3 to 4.4 per 100 person-years. This is the first study providing empirical evidence of a HCV treatment as prevention effect within a prison setting. This is obviously very pleasing and has implications globally for HCV elimination efforts, not just in the community, but in the prison as well. It's also important to note that this is in a setting where harm reduction is limited. So while there is access to opiate agonist therapy in New South Wales prisons, there is no access to a needle exchange program, and so there is considerable risk behaviour. So you can imagine then that if the hepatitis C treatment as prevention program was coupled with improvements in harm reduction within a prison setting, that the reduction in incidence would be even greater. In a similar effort in a single prison in Queensland, they also almost eliminated hepatitis C with a combination of enhanced screening and broad treatment over the course of 2 years. So with broad uptake of direct-acting antiviral therapy and very rapid scale-up over a short period of time in Australia, we have rapidly reduced the burden of infection, particularly amongst current people who inject drugs, with an estimated reduction of 40% from end of 2015 to the end of 2018. There's been a similar reduction of 30% amongst former people who inject drugs and people who have never injected drugs, in the order of 30%. The experience in Australia with universal access to direct-acting antiviral therapy, rapid scale-up, and broad community and political support has shown what can occur in hepatitis C elimination efforts. However, as revolutionary as direct-acting antiviral therapy is, settings that don't have harm reduction will certainly not be able to treat their way out of a hepatitis C epidemic. Opiate agonist therapy and needle and syringe program access are crucial for hepatitis C prevention. As we can see in this meta-analysis, opiate agonist therapy reduces the risk of hepatitis C acquisition by 50%, and there are similar reductions for low and high needle and syringe program coverage. Unfortunately, only 1% of people who inject drugs live in countries with high coverage of both NSP and OST, which makes hepatitis C elimination efforts globally particularly challenging. If we take the example of the United States, we can see an increasing burden of hepatitis C infection. We also know that they've got an increasing number of people who report current injecting drug use, and they have very limited access to harm reduction and restrictions on direct-acting antiviral therapy access in many states, dependent on drug use history. We need to consider how models of care might be shaped so that people who inject drugs can access the care and treatment that they need. In Australia, we've embraced community-based models for people who inject drugs and for vulnerable populations, which includes a number of community-based health clinics and the embedding of viral hepatitis services within other drug health services. There have also been advances in hepatitis C diagnostics in the last number of years, which may be of particular benefit to this population, particularly fingerstick point-of-care hepatitis C RNA testing, which with 100 ml of capillary blood obtained by a fingerstick will give you a HCV RNA result within 60 minutes. This has then led to the thought that we might be able to consider a hepatitis C test and treat type approach, such that people could present for hepatitis C testing, and if they were positive, have a rapid clinical assessment, be commenced on pan-genotypic therapy, given that we know it's safe and effective, and walk out with a script and start treatment on the same day. We're evaluating this approach at the Kirby Institute with 3 studies, 2 in a community setting involving people attending needle and syringe programs and people attending Aboriginal health services, and a 3rd in the prison. We need to remember that if we're a successful elimination strategy requires community engagement. We've done this over the last 30 years with the HIV epidemic, and the approach to hepatitis C and people who inject drugs should be no different. Globally, we have many challenges to hepatitis C elimination to consider. In many regions, there's inadequate hepatitis C testing and diagnosis. There's limited access to care, treatment, and harm reduction. A lack of education and training for healthcare providers. Ongoing stigma and discrimination. Variable leadership and commitment from policymakers and governments. And there are also financial barriers to testing and treatment. But this doesn't mean that we shouldn't try to move the agenda forward and attempt to achieve elimination amongst people who use drugs. To do this, we need to keep a focus on improving the lives of people who use drugs. Hepatitis C treatment and prevention should not be a silo. Ideally, we should enhance hepatitis C screening and linkage to care, and here there may be a role for point-of-care hepatitis C RNA testing, particularly in community-based services. If possible, integrating hepatitis C screening and treatment with services that people who inject drugs already intersect with is useful. This can include drug treatment services, homelessness services, and mental health services. We're moving towards simplification of HCV treatment assessment and delivery. We now have short duration pan-genotypic therapy, so there is minimal workup that needs to be done before someone commences treatment. There's also little to no monitoring that needs to be done on treatment. If possible, jurisdiction should increase direct-acting antiviral treatment in prison. We've seen with the STOP-C study the value of treatment as prevention in this population. We also need to increase treatment uptake in community populations, and this might need to be in settings that we would not traditionally think about, offering screening and treatment in needle and syringe programs, or while people are hospitalised for other reasons. Community organisations should continue to have a role and potentially should have an increased or a more or a larger role in peer-based support and education and prevention services. And ultimately, there needs to be a focus on human rights and drug use. In many parts of the world, the criminalisation of drug use impedes people's healthcare access, particularly for bloodborne viruses. Highly effective hepatitis C elimination strategies require political leadership, national strategy development, partnerships, and universal healthcare. It's technically feasible, but we need to work together to get there. Thank you.